Welcome to Dental Business RX. Practice success in 30 minutes or less.
Thank you for calling ABC Dental.
Improving case acceptance in your practice is a bigger game changer than you might imagine. For one, it can radically impact your collections. And we see this all the time, especially with newer clients that attend the MGE communication and sales seminars. The average client sees about a $300,000 increase in just the first year. I don't know if you like that shameless plug this early in the episode. I'll put a link to this on the episode webpage, but it was just to make a point. It will drastically impact your collections if you get better at case acceptance. But beyond this, there are a number of other benefits. First being job satisfaction. You're not just doing what insurance covers. You're doing what patients really need. You're doing the type of treatment that you really enjoy doing. Then the increased revenues are not only beneficial for you, they're better for the practice. You can compensate your staff better. You can do that promotion you always want to do to get more new patients, upgrade your equipment, and so on. And most importantly, the biggest benefit is for your patients. It leads to healthier patients. Patients are getting all the treatment that they need and really restoring their oral health. It's truly a win-win for all concerned. And it's with that in mind that we address the subject of case acceptance very early in a client's program, with the communication and sales seminars, as well as we get more comprehensive case acceptance training or case presentation training, rather, however you want to call it, as a client gets into the MGE Power program. And the funny thing about this as well is when you learn workable techniques, the size of the case really doesn't matter. You can talk to MGE clients who do, all on X cases, FMR cases that are $40,000, $60,000 and so on. And they'll be the first to tell you that the techniques they use to close those cases are the same techniques they use to close a patient to do 4 crowns. It's the same communication techniques. Where things differ a little bit, maybe more on the amount of time spent in the presentation, maybe there's more work on the qualification process, etc., for a larger case. But the sales technique itself stays the same. So being that we're in and have been in the sales and management training business for about 30 years, we're pretty familiar with what works and doesn't with regards to treatment acceptance. And by knowing what works, you get a really good bead on what the biggest mistakes or errors are that dentists make with regards to treatment presentations or acceptance. Again, I don't know how to say this. Case acceptance, treatment presentations, you know what I'm talking about. And these mistakes are what I want to talk about in this week's episode. My name is Jeff Blumberg, and I'm your host, and I want to cover the 5 biggest, what we've identified as the biggest treatment presentation / acceptance mistakes dentists make, and more importantly, how to avoid them. And look, there's obviously more than 5 mistakes that can be made in this. I could make a list of 50, probably. We're picking the 5 most common or the 5 biggest ones. So with that, let's start with mistake number 1. Mistake number 1 is not assessing a patient's frame of mind before you move forward into a treatment presentation. So let me give you an example of this. Let's say this is the most common one. You have a new patient and you don't really do much beyond the clinical side of things during the exam. Maybe you build a little bit of rapport, but you really don't get into this patient's head as far as, what they think about dentistry or what they want to achieve with their visit today or how important their oral health is or what their prior dental experiences were like and things of that nature, as well as how they feel about the condition of their teeth. The reason I say this is, let's say you have this patient, you've met with them or you've done their exam, they think that they're in great shape, you do the exam and you find that they're really a mess. Well, now you have a problem. You're going to have to present at some point that this patient has a lot of issues that need to be dealt with, but you're running right into the teeth, sorry for the pun there, of the idea that they think they're in great shape. So you really haven't gotten where this patient's headspace is, so to speak. You're going to do this case presentation now and effectively drop a bomb on them. They think that everything was great. You tell them there's all these things that you found wrong. And I'll tell you what the result from that's going to be at least 50% of the time. They're not going to accept anything. They're going to leave the practice and leave a terrible review for your office. A lot of negative reviews have to do with the sales process. So they're going to say, my last dentist said I was in great shape. I went to Dr. So-and-so's office. And they told me I had all these problems, which my last dentist never said that I did. Stay away from this place. They just want your money. So, how do you avoid that? Well, the way you avoid something like this is really getting an idea, and it's best to do this during the exam process because it doesn't take very long, of where this patient is at. So, you're doing your exam. Let's say the patient's there for an initial. You do your initials in hygiene. Hygienist has done the charting, maybe some scans, x-rays, etc., and then you bop in to do your exam. You meet him. Hi, I'm Dr. So-and-so. Ask him some questions. So, what brought you to us today? When was the last time you were at the dentist? How were your last few dental visits? Were there any particular problems you feel weren't addressed? Is there anything that you want to discuss today? So let's say they tell you, no, I've always taken great care of my teeth. My teeth are important to me and things like this. And my last doctor said I had perfect oral health. Then you start doing your exam, you start seeing some problems. Well, I would start dropping hints at that point. You don't have to necessarily get into a diagnosis like, oh gosh, you're going to need a crown on this tooth here. I wouldn't do that. But I'll tell you what I would do. You pull out your intraoral camera and you might go, hey, have you ever noticed that the cusp on this tooth is missing before? Here, I'll show you. Look at that. Do you see that whole cusp is gone? Do you know when that came off? No, I didn't realize that was gone. Or do you see this really dark spot under this crown you have here? How, you see how we call that a margin. Do you see how there's like some stuff getting in there. Do you see? Maybe you use a better word than stuff, but again, stay away from heavy technical terminology. Do you see that there? The patient at this point, they might start asking, well, what do we do about that? How do we handle? Don't worry about it. I just didn't know if you'd seen this before. The reason you're doing this is, we might call it foreshadowing. You're trying to give them the idea, like, no, you're not in perfect oral health. There are some situations going on in your mouth here, so that when you come to actually explaining what's wrong, it's not like they're being completely taken by surprise. Because that's the big problem. They come back for the treatment presentation, or you go to do the treatment presentation, and then all of a sudden, they thought everything was great. Now you're telling them there's all these things wrong. It's a real shock to the system, and you don't want to do that. So you might start throwing that out there as you're going through this. You said this hurt when you bit down. How long has it hurt? Have you ever noticed this there on the tooth? Do you feel this here? Start dropping hints as you go. If they ask, what is it? How do I fix it? Just let them know. We'll discuss that later once I've got all my findings together for you. So they get the idea something might actually be wrong. You might do the same thing where, maybe the person has a chief complaint where maybe they want some teeth fixed, but they've got, perio, and it's not great. They have some 6, 7, 8 millimeter pockets, etc. You might want to point that out to them because that's something they don't realize is a big deal. They should understand why it's a bigger deal. When was the last time you had your teeth cleaned? Have they ever done scaling before? Did anybody ever point this out to you? You got this pocketing. Explain to them why that is. And this is before you do any type of treatment presentation. The idea being that you're getting into this patient's headspace, you're learning where they're at, and then if they're at a point where they think everything is great, you're starting to give them hints that maybe not everything is great. It also gives you a really good idea when you get to the actual sales process to know what this patient thinks. Like, let's say you're talking to them about prior dentistry or dentistry in general, and their first thing they say to you is, I only do what insurance covers. Well, that isn't an immediate, doesn't make them not qualified for your services or something like this. All that would tell me is, okay, this person's going to need a little bit more work than someone who doesn't say that. And I'll factor that in when I actually go to present treatment. That would be my thought process. I want to get to know the person, and ideally I'm doing that during the exam before I actually start the sales process. Not just clinically, I'm just not doing diagnostics to get to know them. I'm getting to know them, so when I go to present treatment, I have an actual proper assessment of how much work is going to be involved in explaining the treatment plan to this patient. Not doing that is a big mistake we see a lot of doctors make. And if you want any evidence of this, just go on Google and look at negative reviews associated with treatment presentations, and you'll see what I'm talking about. All right, this brings us to mistake number 2, which is using a ton of dental terminology to explain the problem or treatment and not making sure the patient actually understands. In any profession, you're going to have a lingo or a terminology or a vocabulary that's going to sort of develop. And that it goes beyond medical terminology even. You'll have abbreviations that you use or ways that you refer to things in the office. Instead of a root canal, it's an RCT or an SRP for scaling and root planning. Every profession does this. But your patients aren't necessarily in the fold, and they don't know about this stuff when you're talking to them. So keep in mind when you're speaking to a patient, you're not speaking to a dental assistant or a dentist. So Try to make sure that your language is accessible. It may sound cool, you're using all this technical terminology, but the only effect that you're creating is they have no idea what you're talking about. So things like arches, anterior sextants, abscesses, say infection instead of abscess, periapical radiolucencies, distal, buccal, occlusal. Use words the patient understands. If you have to use a word that they are not familiar with, maybe for a procedure or something like this, then explain what it is. Because if you don't, and this is just something I've found over the years, people just don't ask questions. I think maybe because if you're giving them those words, if you're saying those words, they expect that they should know them. So they feel like if they ask a question, I'm just assuming this, by the way, that's going to make them look stupid, and people hate looking stupid. So don't make them feel like they have to look stupid. If you're going to use technical terminology, explain it to the patient. And also, it doesn't make the treatment any more real to the patient, because keep in mind, you're selling a service. So if you're explaining to a patient, and some people do this and some people don't, but if you're explaining something to a patient, some things are easy to explain. So you see this cusp here is missing on your tooth. So we're going to do a crown here or an onlay or whatever it is we're going to do. What's an onlay? Well, it's this. You might even have some lab cases laying around of patients you didn't deliver to, or some models where you can show them, see, this is an onlay. So they can see, I'm going to make this, and then your tooth is going to look just like the tooth, on the other side of your mouth. It'll look just the same. More or less, you'll have a hard time telling the difference between the two. In other words, you're selling a service, so try to make that service as real as possible. Models, lab cases, etc. Because again, you may think that people know that they don't. If they don't know what an implant is, you can bring out the big model, but then I'd actually show them a real implant. So they can see this is the size of the thing going in your mouth, and this is how we're going to restore it. If you're going to have to bring up terminology that they're not familiar with, but try to make whatever it is that you're explaining to them as real as possible. Because again, it's not like you're selling them a couch that they can sit in and they can look at, and it's right there. It's a service that you're going to have to perform. They're eventually going to have in their mouth. And this is why I love the before and after pics, where you can model what their mouth will look like before and after. Those are great if you can do it. But if you can't, models, old lab cases, etc., to make it more and more real. The more real it is, the more interested they're going to be in proceeding. So that's mistake number 2. People don't do that. Mistake number 3 is not allocating enough time for sales. I've talked about this before on the podcast. This is a really big one, okay? And in dentistry in general, we allocate, just in the profession, we allocate time for treatment, and we allocate time for diagnosis, but we don't allocate time for sales, which is silly if you think about it. You're allocating time to do that exam, fine, and you're determining what the patient needs, but then we're allocating little to no time to explain it to the patient so that they actually want it and buy it, and then we're allocating time to actually do it. It's a little silly that we're missing that step. That's kind of a key step between diagnosis and actual treatment, is the patient has to agree to it. So you have to allocate time to be able to sell. From a mistake perspective, how does this normally look? So let me give you 2 examples. Let's say we have a new patient initial, and you do your new patient initials. You allocate an hour, and they go through hygiene, and the hygienist sees them, and they do all the charting and the x-rays, etc. Well, not the dental charting, but they're doing the perio charting. And then you're going to come in for the last 20 minutes, meet the patient, and do the exam. So let's walk this forward for a second. So you go in, you're going to spend 20 minutes. How long is it going to take you to meet the patient and do a proper exam on this patient? It's probably going to take anywhere from 10 to 15 minutes. So let's say you do that, and the patient needs, a considerable amount of treatment. Let's say $8,000, $9,000, $12,000 worth of treatment. And someone may look at it and go, well, $6,000, $7,000, $8,000, that's not a large treatment plan. And for you, that's probably true. But for a person to spend $6,000 to $8,000 if they make $60,000 or $70,000 a year, that's a big deal. That's more of a conversation. So you have to look at it from the patient's perspective, okay? So you spent the first 10 or 15 minutes of that 20 that you've been scheduled to be in this room, meeting the patient and diagnosing what's going on. You now have about 5 minutes to explain the treatment that you've found. In a lot of cases, that's just not enough time. So there's your new patient initial. How about a recall appointment? Because this is a mistake people make. They don't present treatment to a recall patient more than once. They present it when they're a new patient, then they just don't talk to them when they come for the recall visits. But let's talk about a recall appointment for a second. You have a patient in recall. They need 3 crowns. They said no last time they were in. Well, they're back, 3 or 4 month recall, let's say, and they're due for an exam. You walk in, or let's say it's 6 months. They're due for an exam. You walk in. How much time after the recall exam do you have to actually present those 3 or 4 crowns that they needed? Again, you got 2 to 5 minutes. You don't have enough time. So you didn't have enough time in that initial example I gave you a minute ago, and you don't have enough time during that recall exam. And the funny thing about sales, it's better to not start the sales presentation than to start it and not finish it. I'll say that again. You're better off not starting it at all than starting the sales presentation and not finishing it. Because if you don't have enough time to actually finish the sales presentation, you leave the person in their sales resistance, and then they leave your practice and they're thinking about it and they don't come back or whatever. So what do you do? There's a few things you can do here. I'm going to give you 2 ways to handle this. Let's talk about a new patient to begin with. Well, the first thing I would handle this with new patients and patients of record is you need to build time into the schedule for treatment presentations. We call this consult time. Because that $8,000, $6,000, $7,000, $8,000 case with this new patient, how long is that going to take to properly present it? And by present it, I mean explain the problem, explain the solution, tell them what happens if they don't address it, discuss the fees, and answer questions. How long is that going to take? That's probably going to take at least 20 minutes, okay? So you build time in the schedule for sales, for consults. What I normally recommend is first thing in the morning and first thing after lunch. Sometimes for larger cases, if you're doing FMR or all-in-X type cases and you maybe need an hour, you can, let's say you don't work on Fridays, do those Friday morning, okay? If they take you an hour. But otherwise, if it's your normal run-of-the-mill bread and butter dentistry and you just don't have time to present it today, see them on first thing in the morning, first thing after lunch. This has a few benefits. Number one, if I have 2 20-minute consults first thing in the morning, there's a few things that happen. Number one, I do those before I'm, as the doctor, you're into patients. So then you're not stuck in the middle of the next patient while you're trying to present treatment because you want to be distraction free when you're talking to a patient. So there's benefit number one. Benefit number 2 is if I do primary procedures in the morning, I like doing larger procedures in the morning, higher dollar procedures in the morning. Let's say my procedure for today canceled at the last minute. They, had a family emergency and had to leave town. Well, I've got 2 consults this morning. There's a good chance one of those patients can, if I close them, could stay and get the treatment done today. I could save my day. So, the first patient I see, go through the treatment presentation. They go, "Doc, this sounds great. I'd love to start." And I say, by the way, a half hour from now, I just ended up with another opening. If you want, you could stick around and get you a cup of coffee and I could just start the treatment today. In some cases, the patient might say, "Well, doctor, I just so happen to be off today. That'd be great. We could start this now. I'd love it." Right? So it can save your day. First thing after lunch is great too, because if you end up, working through lunch or whatever, you can grab a sandwich and just see the patient first thing after lunch, or you're at least not involved in other patients coming back first thing after lunch. You're doing your consultation, okay? So build time into sell, and if you don't have time to present, bring those new patients and those patients of record back during your consult time, ideally within 1 to 3 days. And I wouldn't get into a huge treatment explanation when you're trying to bring them back, and the doctor should be involved in this discussion. How might that look? So let's say you finish with the new patient and you see that you're doing the next chair 5 minutes from now. Then you might say, "Great, well, here's what I'm going to do. I'm going to look over all the data I've gathered today, review your x-rays, your charts, your scans, and then I want to meet with you personally, and I want to go over what I found and what I'd like to do about it to address what's going on in your mouth. I'd like to see you within the next 1 to 3 days." And you could even ask your assistant or hygienist, like, "Hey, when is my next consult appointment available?" Day after tomorrow, doctor, at 8 o'clock. And you can turn to the patient and say, "Hey, could you be here day after tomorrow at 8 o'clock? Sure, I can do it. Great. I'll see you then." So you bring them back for the consult. Let's say the patient pushes back. "Well, can't you tell me what's going on now?" You can just say, "Listen, I want to make sure I review everything to make sure I come up with the best course of action for you. Give me time. I want to make sure that we do what's best. And then when we sit down, you and I are both going to sit. It's just the 2 of us. I'm going to explain everything, answer your questions or whatever, so that you can make sure so I can make sure we're on the right path here." Usually patients will respect the fact that A, they're getting to sit down with you one-on-one, and B, that you want some time to really review their case and figure out what's going on, which obviously you could do it on the spot, but it's a way to at least address that issue when the patient asks the question. So if you don't have time to present to the recall patient or the new patient, you bring them back for a consult. That being said, the ideal situation is to present same day. That is the ideal situation, because I've seen people misunderstand this and go, "Oh, so I'm supposed to bring everybody back for a consultation." Absolutely not. If I could present the treatment plan now, why would I want to wait? Of course I want to present it now. So is there a way around this? There is. Specifically with the new patients, there's not much you can do about this with patients of record, although a patient of record will take you less time to explain because they know you. But with a new patient, there's two things you can do. One, the average office for a new patient initial, especially if it's going through hygiene, is scheduling that patient for 1 hour. That's the usual, and the doctor gets the last 20 minutes of the appointment. Assuming that whoever's answering your phones and handling new patient calls can do this. This is a big thing. Whoever handles your new patient calls has to be able to do this before you implement something like this. You could have an intake form that's very thorough, and if you'd like, I'll put a copy of one of the intake forms from our online platform, New Patient Intake Forms, DDS Success. I'll put a link to it on the episode webpage to both DDS Success as well as the intake form. The intake form is free if you want to download it. If you ask the right questions, you should be able to determine, not fully, but you should be able to determine to one degree or another if this patient needs more extensive or no extensive work, okay, if you ask the right questions. Now, is this going to be an absolute? Absolutely not. Is your receptionist diagnosing? Absolutely not. But what is the receptionist doing? They're asking questions like, when was the last time you saw the dentist? Did the dentist recommend any treatment? Did you do it? Are you missing any teeth? Are you in pain? Do you have any teeth that are sensitive to hot or cold? Is there anything in particular you would like to discuss with the doctor while you're here? Is there any problem that you want to make sure we address while you're here? So let's say you're asking the patient these questions while you're doing your new patient intake, and all of them are no. I was at the dentist 6 months ago before I moved and everything was fine. Well, that patient gets the 1 hour initial because you're going to spend the 20 minutes. They may or may not need treatment, but if you do, you bring them back for a consultation, right? Maybe they need Invisalign, and you want to spend some time explaining it, you bring them back for a consultation. In most cases, if you do this, they won't need extensive amounts of treatment, or if they do, you just bring them back. But let's say the answers are, yes, I'm missing 3 teeth. Yeah, the last doctor I saw wanted to do some implants. I didn't get a chance to do them. Yeah, I'm in pain in my lower right side. A couple of my teeth hurt, especially when I drink hot or cold things. Like they're telling you they need potentially some major treatment. Okay, again, we haven't diagnosed anything, but with those patients, we're going to schedule them for an hour and a half. The 1 hour on the hygiene schedule with the last 20 minutes being the doctor, and that last half hour of the hour and a half is going to be with the doctor explaining the treatment plan. We've built the sales time into your schedule. So then there's the doctor and the treatment coordinator explaining the treatment plan. The sales time is already built in. The only time this can backfire on you is if you get to the end of the treatment presentation and you get objections like, oh, I need to talk to my husband or my wife, and they're not there and they're not reachable. It's the only way it may backfire. Whereas if it was a new patient and you were going to have them brought back for a consult, you could even ask them, hey, when you're making healthcare care decisions, do you make those on your own or do you normally have your spouse present? And they go, oh, well, my wife's got to be there. Then you schedule both the husband and the wife there at the same time. And maybe the wife's not a new patient. You might get a new patient on the deal too. But that's a big mistake, is not scheduling enough time for that treatment presentation, because you're half presenting and you're sending the patient off in the middle of all their sales resistance. And, you know, when you're in the middle of sales resistance, you don't really work yourself through real well. You're better off getting them to the point where you can either close them or not close them, answer their questions, etc., which really depends on the person. I would say the average for the average size case is maybe 20 minutes. Bigger case, maybe a person who's a little bit rougher might take a half hour, 40 minutes. I leave that up to you. All right, so what's our next big mistake? Well, I've brought up that the doctor is doing the treatment presentation. The doctor also should discuss the fee. Now, some doctors do, some doctors don't. Doctors that are trained here at MGE are trained to discuss fees with patients. Not discussing a fee with a patient is a mistake from the doctor perspective. You might go, you know, Jeff, why would the doctor discuss the fee? Well, ask your staff, who is a patient most likely to listen to? You know what the answer is going to be. They're going to tell you it's the doctor. Okay? So the doctor discussing the fee with the patient when they explain a treatment plan is more powerful than you think. I've seen it affect statistics in the most bizarre way, you know, where you'll have a doctor who just for one reason or another stopped discussing the fee, and then their collections drop by $20,000 or $30,000, and then they start discussing fees again and they go up by $20,000 or $30,000. It's that impactful. So assuming you have enough time and you've explained the treatment plan to the patient, you know, the problem, the solution, the consequences of not doing anything, there's going to come a point where you as the doc have to discuss the fee. The patient's either going to ask or you're going to get to the point where there's nothing else to talk about. So that's when you can, you may have a little sheet which explains all the procedures and how much it's going to cost and what you're expecting from insurance. So what would I at minimum expect the doctor to do? Tell the patient, well, this treatment plan is going to cost $10,700. Here, see? We're expecting your insurance to pay about $1,500, which would leave your copayment at $9,200. And that's it. That would be the minimum I would expect a doctor to do. Now, what is a patient going to say when you tell them this? They're going to say, that's a lot of money. Oh my gosh, I don't know how I'm going to afford that. Wow, I didn't expect it to be so much. Or maybe it's less than I thought. Who knows? You're going to get any range of responses. In a lot of cases is, wow, that's a lot, or that's really expensive. So you could do a couple things at that point. If you're not comfortable, you could then turn it over to your treatment coordinator. Hopefully your treatment coordinator's been with you the entire treatment presentation. You go, well, that's why Jane's here, and I'm going to have you work with Jane to figure out, different ways you could go about doing it. That would be, in my opinion, sort of the, the irreducible minimum I would expect from a doctor. What's the better way? Well, let's say again, so your treatment's going to cost $10,700. So your portion's going to be about $9,200. They go, wow, that's really expensive. Well, then you might say, good. Well, do you understand the treatment? Yes. Okay, good. Do you really want to do it? Yes, I do. Okay, good. Well, how would you normally take care of something like this? The patient can think, well, I don't know, I guess I could throw it on a credit card. Okay, do you know which card you would throw it on? Yeah, I have a Visa, I think that would hold that. Okay, great. Well, do you have any questions about the treatment? No. Okay, good. Do you want to do it? Yes, I do. Okay, good. So here's what I'm going to do. I'm going to turn you over to Jane here, our treatment coordinator. And Jane is a wizard at figuring these things out. You guys can figure out exactly how you're going to pay, maybe use that VC you want to use. But the most important thing is that we get this treatment done, right? So next thing would be, I normally do these procedures first thing in the morning. Let's say you like doing primary procedures in the morning. So, Jane, when is my next morning appointment available? Well, day after tomorrow, doctor, at 9. Could you be here day after tomorrow at 9? I mean, I'll let you work out the finances with Jane, but could you be here day after tomorrow at 9? Yes, I can. Okay, great, good. I look forward to seeing you. You're in great hands with Jane. We'll let you guys work all this out. If you guys have any questions, you just come grab me, okay? Great. And then you're out of the room. The patient's already agreed they're going to put on a Visa, this, that, the other. Now, other things may come up when they go off with Jane. Well, can I only do what the insurance covers for now? In which case, you're going to have to be called back in because Jane can't decide which teeth we're starting on. Or the patient doesn't want to use their Visa. They want to do a payment plan, in which case, fine, they're applying for patient financing at that point. But you've gotten them to the point where the patient really wants to do it. The patient knows how much it costs. The fact that it came from you is powerful. And I don't know if you noticed that last thing I talked about there, you're taking some degree of control on your schedule because, again, the patient is most likely to listen to the doctor. If you want to do primary procedures in the morning, you're telling the patient, this is when I do these. Here's when I'm available. Can you come in on that day? Now, of course, you're not finalizing the appointment or your scheduler is probably going to kill you. Not, literally, but figuratively. But at least you've now planted that seed in the patient's mind, right? So not discussing fees from the doctor's perspective is a big mistake in my view, definitely with our clients. If I had a client who stopped doing it, we would correct that as quickly as we can because it makes such a big difference statistically. Try it and see how it goes. And, look, maybe you're thinking, gosh, I can never tell a patient how much something costs. I'm worried what they would think. Yeah, some people are going to think badly of you and, okay, but most people won't really care. If you're not going to please everybody. And usually the people who are going to think badly of you or give you a hard time because you gave them the fee, I don't want to apply this as a general rule, but a lot of those patients are probably patients that you really aren't a good fit for your practice anyway. So if you find it uncomfortable to discuss fees, you could do a few things. First thing I would do is look in the mirror and start reading fees. This may sound stupid, but drill it a bit. Okay, this treatment plan is going to cost $10,000. Because some doctors, they go to say this treatment plan will cost, and it's almost like they throw up in their mouth, 10. No, just explain how much it is, and then try it. You're going to be nervous the first time, and you do it. And you'll notice that the patient doesn't get upset with you. They just listen, and they go, "Wow, that's a lot of money," and then you can turn it over to your treatment coordinator. Do this on a gradient if you want, or maybe you're a little bit further ahead and you're ready to take that next step and go, "Okay, good. How would you normally take care of something like this?" It makes a massive difference. Is my only point. I advise you to try it. It is a game changer. I know that improving treatment acceptance is the game changer. This is a big part of the game changer. All right, which brings us to our last mistake. What is the last mistake? Well, it's discussing finances without first making sure that the patient actually wants the treatment. Now, I don't know if you noticed in that little example I did a minute ago, I don't know, I'm doing it with myself. It wasn't like when I asked the patient, it's when I asked myself playing the patient. The thing I asked before I got into the fee was, do you want to do this treatment plan? Do you have any questions? And is this something that you want to do? Why ask that question? Well, because I've seen people who are comfortable discussing fees. They don't verify that the patient actually wants the treatment, and then they get into the fee, and then the fee discussion just starts escalating out of control. Well, I can't afford that. That's a lot of money. Well, have you thought about applying for financing? No, I can't do that right now. You thought about this? No, I can't do that right now. It's just problem. Why? Because if they were to go back, and sometimes they do this, they go back and go, look, do you actually want to do this treatment? And the patient says, yeah, I don't know, maybe, I guess. If a person says, maybe, I guess, about doing a treatment plan, why are you discussing the finances of the treatment plan? They don't even want it. Why would I argue about money or a person paying for something that they don't even really want? That's a waste of time. So ideally, before you get into the financial discussion, make sure the patient really wants the treatment. You could straight up ask them, okay, do you understand what I'm explaining to you? Good. Do you want to do this? And if the patient hesitates, I don't know, I think I need to think about it, I'm not sure, then there are questions you've not answered, there's more things to discuss. Explain the treatment again and why they need to do it before you get into the fee. Conversely, let's say the fee discussion just isn't going well. It's problem. Backtrack. Listen, do you want to do this treatment plan? Is this something you want to do? And look at what they say. Again, if the response is, I don't know, well, then stop talking about the finances and get back into why they need it, okay? Because ideally, and you've seen this before, if a person really wants something, they will figure out a way to make it work. That's how that goes. And that's just what I've seen. If someone wants to really make something go right, they will make it go right somehow. They'll go get somebody to co-sign, or they'll do this. They'll move heaven and earth to get what they want because they really want it. So don't get into a huge financial discussion, or if you find it stalling, go back to, does the person actually want the treatment? And if they don't, or they're unsure about it, go back into explaining the treatment again. So that was mistake number 5. And look, there's a lot to know about treatment planning, treatment acceptance, patient communication, etc. We do a ton of training on it. Those communication and sales seminars I mentioned earlier, which I have a link to on the episode webpage. All I can tell you is if this is something that you've been thinking about, or it's an area that you feel like you need to improve, or you would like to improve your collections, this is exactly where I would start you, and we'd be more than happy to help. Just click that link, find out more, and we can help you. All right? Anyway, I hope all this helps. I'll put those links I mentioned on the episode webpage. I have the links to the communication and sales seminars. I have a link to the Power Program. I also have a link to the to DDS Success, as well as that new patient intake form. If you want to download that, that's free. If you want to know more about MGE, you can find us online at mgeonline.com or call us at 800-640-1140. Folks, have a great week, and we'll see you at the next episode.